Okay, great. So, I see a few more people are going to be joining us. So, I want to make sure that I honor everybody's time. So, we're just going to start in here in a minute. There's a few more people trying to join, and I want to make sure we can get everybody being able to attend. Okay, great. So we'll go ahead and get started. I want to make sure that we respect everyone's time this evening. I wanted to welcome everybody this evening. Thank you so much. It is November, which is Epilepsy Awareness Month. So this is really important not only for this month, but just, throughout the year. We do have these wonderful educational webinars. So please be on the lookout through our website as well as our newsletters and our social media platforms because we do update that quite frequently. So, any programs and events you guys are interested in being a part of and joining, that's a great place to start. As well as I'm Miriam Swanson with the Epilepsy Foundation of Northern California, and I'm the program manager. So, any questions you have, you want to be a part of with the foundation, I'd be happy to answer. And I will put in the chat as well my email. So don't hesitate to send me an email as well. And we are so thankful and appreciative for Dr. Toprani for being with us this evening with UC Davis. And we have a wonderful presentation for this evening. And I just wanted to say a few notes. So when you guys came in this evening, you guys are all muted. And if you guys can please stay muted, it helps the presenter that, any background noise that it doesn't interfere. But Dr. Toprani did want to let you guys know that if you do have any questions along the way, she's more than happy for you guys to stop and ask the question because it is kind of a very comfortable ongoing presentation. And then at the end, there will be Q&A as well that you can ask your questions. And Dr. Toprani is very happy to assist and answer that she's able to. So with that, I will let Dr. Toprani take over and thank you again for each and every one of you for being here this evening.
Thank you so much, Miriam and Carlos, and everyone for joining me this evening on a Wednesday night. I hope that the topics are relevant for you, and I'm happy to, like Miriam said, steer this according to your questions and interests. So I've got things to share, but I'm happy for it to be a discussion. Just don't have to get through all of these slides. Talk with me. The main topic is going to be how cognitive networks intertwine with seizure networks. And I am an adult epileptologist, so it'll focus mostly on my knowledge of adults. But as you know, it's a spectrum in one brain that grows up. So maybe I can answer your questions about kids as well. And to say a little bit about me, thank you for the introduction already, and it's great to meet everyone. I am an epileptologist now at UC Davis, and so proud to be part of the UC Davis epilepsy team. My clinical passion is personalized treatments that consider patients' quality of life priorities in addition to their seizure outcome goals. So whether it's trying to get down the number of seizures as much as possible or you know, making sure that whatever treatment you get, you can scuba dive and want to hear that and consider that and really understand your brain and how these two networks interact to come up with treatment plans that are optimal for those goals. I work mainly with patients who have epilepsy that hasn't benefited significantly or in a desirable way with medical therapies and are looking for next step options for them. I'm early in my career, and after lots of training, which I've listed out my path to how I got here on this slide, I'm developing a practice that's really focused on diagnosing epilepsy within the context of the brain and the person, and to improve the ability to treat both of these with innovative therapies, including electrical stimulation. And I spend a lot of my time doing research on this topic and currently focused on discovering how changing brain networks interact with changing seizure networks across cognitive and seizure states. Because as you know, you don't have seizures all the time, and maybe your cognitive states fluctuate as well. And this dynamic thing is very much a part of epilepsy. And because the whole person and environment are everything, I also researched stigma in epilepsy in high prevalence regions of Cameroon, in addition to developing tools for remote neurological assessments. I've studied connectivity in seizure networks, electrical stimulation therapies for epilepsy in depth in both the lab and hospital settings. And I've done various clinical studies relating to epilepsy, cognition, or electrical brain therapy. And so now that you know who I am, I'd like to introduce the idea of epilepsy as a syndrome that's more than seizures. So talking about how treatments affect both seizures and cognition, and also going over what to look for in building thorough care plans that considers seizures as well as cognitive outcomes. I want to share some tips on defining your personal care goals and how to help your doctor get on the same page as you about your vision. And then finally, the extra fun stuff. I will invite you to explore new possibilities with me by geeking out a bit about research. Throughout this talk, I'll be wearing both my medical doctor and researcher hats. So I'll include research diagnostics as well as treatments, in addition to things that are standard of care. So getting started, for most people with epilepsy, seizure time is about 1% of their lifetime, which was a really shocking number for me to read. Seizures can occupy minutes per day and not every day. And yet morbidity reports show significant impacts of epilepsy. Is this all because those few minutes have huge effects, which they do? Or are there symptoms that affect quality of life in addition to worrying about having lifestyle compromises for safety due to seizures? There are reports that epilepsy symptoms are more than seizures. And those other symptoms have a significant impact on quality of life independently from seizures. These symptoms can include cognition, energy, mood, and psychosocial symptoms. And while there are multifactorial causes contributing to this, so in addition to changes from the disease itself, having a chronic disease certainly affects a lot of these things, and medications you probably all know also affect these things. There is a direct link between epilepsy itself and these symptoms. When a wave of electricity spreads through the epilepsy network, but not with enough strength to be experienced as a seizure, people may feel some of these other symptoms. Seizures are a part of epilepsy, but not all of it. And quality of life drops in 60% of patients with epilepsy because of the cognitive and other symptoms. So as we talked about, these symptoms come for multiple reasons as a direct result of electrical changes in brain circuits, because of treatments and because of living with a chronic disease, which can be misunderstood or stigmatized and requires care support as well as lifestyle adjustments. In addition to the causes being multifactorial, the effects on cognitive networks are also multifaceted. So intelligence, language, memory, executive function, and psychomotor planning, I mean, these are all important widespread parts of the brain. And so when you have this seizure or changes in the brain that occur with seizures happening, any of these can be impacted. And this is the case whether there's an epilepsy that's location related or something like a primary generalized channelopathy or a genetic epilepsy that kind of affects the whole brain at the same time. So to change this and address this properly, the link between seizures and these neuropsychological symptoms of epilepsy can be described. And I think of networks as the key to that link. So there's this really great depiction of intertwining rope by an artist. I'm not sure how to say her name, Janina Landini, but I think of this as kind of how a brain with different networks looks, or maybe a subway map as good ways to visualize these network interactions. So there's a seizure route that intersects differently with computational, emotional, or movement routes. It may or may not travel near language or vision routes, but may still affect them by being a key hub where issues can cause traffic jams, affecting parts of speech or how you use visual input. Things get complicated when you add in train speed and weight where a particular train is. But as you can see, things are interconnected within your brain, and seizure networks are part of that brain. Excitingly, there's increasing recognition of epilepsy's impact beyond seizures. So, epilepsy across the spectrum is an initiative by the National Academy of Medicine. And this is meant to be inclusive of electrical and cognitive symptoms. So let's talk about the factors related to epilepsy itself that affect cognition. The broad categories are shown here, and let's dive into them. So the first is the types of epilepsies. And we'll use, starting with the old way of using epilepsy syndromes, which is what you see on the left. But from now on, let's consider it as inclusive of the left and right column. So it's not just the description of the type of seizures, but it includes the type of cognitive symptoms that tend to come with that type of seizures. So this includes the childhood epilepsies, progressive epilepsies, and focal epilepsies. And there's a varying degree of impact. But as you can see, different circuits are affected. You can have executive attentional issues. You can have very specific, if people have loved ones with Landau-Kleffner, know how this affects language and the ability to process what's heard. It affects intellectual ability and developmental regression with West syndrome or Lennox-Gastaut. And then with the focal epilepsies, the symptoms you see often correlate very much with the region where the seizures are coming from. So with frontal epilepsies, executive function, attention, and speed are affected. With temporal lobe epilepsy, which is the most common type of epilepsy, or at least of epilepsy that doesn't respond to medications often, you can see material specific memory and naming being affected. And then with parietal and occipital, it says unknown because those are often harder to characterize, but things like visual inputs and emotional inputs, sort of spatial planning, are some things to look out for. So let's talk a little bit about the age of onset of epilepsy. What we do know is that cognitive symptoms are worse in people who've had earlier onset epilepsy. But what we don't know is what's really the cause of this. Is it a cumulative effect of having epilepsy for a long time that's not adequately treated, that's kindling other parts of the brain or causing ongoing brain changes? Or is it due to an epilepsy happening early on when the brain is developing and changing how it grows? What we do see, though, is that when we compare people with similar types of epilepsies who had the onset at an older age relative to a late age, at the same age, test performance on neuropsychological tests and have lower scores in people who started having seizures earlier in their lifetime. And this does come with actual changes in the landscape of cognition within the brain. So in people who had temporal lobe epilepsy starting early, the dominant temporal lobe, which is often the left temporal lobe, is responsible for language in the vast majority of patients. And what you may see if that person had seizures starting there early on is a displacement of the language area, which can correlate with a change in IQ if it's outside of Wernicke's area, which is the typical area that you may expect it in. So the more widespread the language centers are found to be, the more that can affect IQ, language, verbal memory, and education outcomes. And so continuing to talk about this, with early onset epilepsy, you do see changes, reduction in brain volumes. And we think about both the gray and the white matter. So the gray matter is the cell bodies, and then the white matter is the highways that connect those cell bodies, which are the storehouses of information. And so both the gray and white matter are reduced in people of the same age who had epilepsy, again, starting at an earlier age. And this can affect most of the important lobes of the brain. And so, once again, this is an issue of a brain under construction, being constructed differently. Maybe it's unclear how much is that versus the long cumulative effects. We do see less education, effects on employment, on marriage, on physical health, and more psychiatric disorders in patients who've had epilepsy for longer. Um, I wanted to show an image of diffusion tensor imaging, which is that really cool, colorful image of the brain as a representation of the brain's highways. So one of the other circles, in addition to when epilepsy started, is kind of how severe it is. So kind of along the lines of that question of the cumulative effects of ongoing seizures. We do see that the more seizures there are, so maybe not necessarily that they started earlier, but if medications aren't working and you have a patient that's having more seizures relative to one who's having less, you see decreased volume on the side that the seizures are coming from, very significantly. So those numbers are the negative 271, so way less than your average population versus plus 12 in patients with the same disease phenotype, but with well-controlled seizures or who are seizure-free. Um, However, seizures, I think of these as sparks, and you guys might have heard the term kindling. And there's a quote, "A spark is a little thing, yet it may kindle the world." And that's what these seizure sparks can do too. It'll rile up the other side of the brain or activate other areas. And so in patients where seizures are ongoing and not adequately controlled, what you actually see is a significant loss in volume in the contralateral temporal lobe as well, relative to to patients who are seizure free. And these people, not surprisingly, have more cognitive sequelae than patients whose seizures are well controlled. And verbal learning and memory are affected. And like we talked about in the last slide, this has quality of life outcomes, that affects everything that we do. So talking about when these changes occur, you've seen cognitive disruption that can occur during and after seizures, this post-ictal state. And so not surprisingly, if you examine someone, during the seizure, you can see the difference. And this is a really visual example of that, where you ask someone with right central parietal seizure. So like I said, that's an area where spatial awareness can be. And it's really helps you kind of look at the world in front of you as a whole. So when a part of it is impacted, you may ignore the contralateral side, and your sphere shifts and shrinks. And so when you ask people to bisect the line, cut the middle of it in half, they do it well when they're not seizing, and you can see their image of where the half point is shifts during the seizure. Similarly, when they're drawing the cross, there's parts that get ignored during the seizure. And there's all kinds of other symptoms that can occur. So awareness, of course, is affected during or after seizures. People can have contralateral paralysis, known as Todd's paralysis, issues with speaking or reading. And there's been an effect known as crowding that patients may experience even in between seizures, and especially during, which is what you can see is loss of symptoms that don't correspond to the seizure location. So an example of this is, if you think of vision as being in the back of the brain and the seizures are somewhere else, let's say where language is, but when seizures are occurring, the brain will compensate by trying to move language and trying to use the circuitry and the cells and other parts to take over whatever is missing. And so this is called crowding. And so you can see the brain sort of losing other functions as it tries to accommodate for that. And I heard,
Dr. Toprani, sorry to interrupt. I think we're having some technical issues. The sound is not very clear. Are you using your computer audio or using your phone?
computer audio, I just turned up the volume. Is that any better?
It's statically, like it's not very clear. Could you maybe use your phone and call the number um, for the actual audio? Let me send it to you real quick. I'll put it on the chat. It should be hold on a second. There should be a direct phone number you can call and try to use the audio through that. Yes.
Recording. Is that, oops, let me mute myself. How's this?
That's better. Much better.
Okay, great.
Yeah, much better. Whatever you did, it works. Thank you so much. Sorry about that.
No, thanks for letting me know. Okay, so to keep going, so talking about, we talked about, not surprisingly, when you're having seizures, cognition can be impacted. But what is, I think, a little more surprising is that during spikes that occur between seizures, so this is that this depiction of the spike that you see here. This is what we can see on your EEG sometimes, even when we don't capture a seizure that suggests that they might be happening. And it's always been believed that these are asymptomatic, but that's being questioned. That, when people do have these spikes or have more spikes on a certain side, you can actually see a reduction in how in getting tasks correct. So more incorrect answers in a spatial task. Thanks. I'm seeing all the much betters. I'm glad. And then including in a verbal task as well. And in fact, if you have issues on your dominant verbal hemisphere, you may not even be able to participate in a verbal task during an interictal spike occurring. And this has been correlated in time as well as in space by where the spike occurs. So reaction time can be delayed during a spike. And you can see that there are missed responses or decreased reaction or increased reaction time that tends to occur temporarily right around when a spike occurs. And the reason patients are least happy with me is the issue with driving with epilepsy. But to kind of complicate things, it's not only seizures. In fact, when people did experiments looking at virtual driving decreased, and people actually crashed virtual cars when they were having interictal spikes. So the impact of this on cognition, on all kinds of things, is important to think about. And so this is sort of, a summary by Dr. Herman, who tried to look at, can you predict the severity of cognitive symptoms, or kind of cluster them into different classes of severity and understand what contributes to them. And not surprisingly, people who had more severe symptoms in all of these categories, so including language, perception, executive function, memory, had decreased brain volumes in both the gray matter and the highways, the white matter. And the factors that contributed were all of the things we've talked about. So the type of seizure syndrome, the age at onset, the etiology of it, how severe ongoing seizures are, and how often this epileptiform activity is occurring, as well as what it looks like. What we don't know, again, is the chicken and the egg. So we've seen that when we have these spikes that occur between seizures, they hijack the network, right? So you do get symptoms during them. So they're interfering with the network that would be doing this other thing, that would be helping you speak, that would be helping your memory, and getting caught up in this seizure instead for a moment. But if that happens repeatedly, it actually diverts the pathways within the brain, and the brain remodels around that. So we know that seizures affect brain, but we also see changes in brains of people with epilepsy that can't be explained by medications. And sometimes we see these in patients who have epilepsy risk or in the genetic epilepsies even before they actually start having seizures. So so we do know that brain changes can precede seizures, can precede these spikes, and maybe the brain abnormalities cause the seizures, cause the spikes. We also know that that happens. And in fact, maybe you need a vulnerable cognitive state to allow the spikes to happen. So it's one thing to think about the spike happening and interrupting your language, but maybe there's something going on in the language network, for instance, where the defenses come down a little bit and allows the spike in and increases your susceptibility. And also, not all networks are created equally. So speech and memory are in that dominant temporal lobe, for example, and the spikes are way more likely to interfere with memory than with speech. So it's complicated. And then finally, in terms of the chicken and egg, maybe something else came first, because we know that there are things that happen first, such as a developmental injury, after which you see both of these things happening. We also know that abnormal white matter connections, so abnormal highways, can affect development and can affect brain tissue wiring, which again you would expect to have either of these outcomes. And so, since we've talked about all these cognitive symptoms that occur with seizures, I do want to take a minute to talk about the other side of the coin, which is cognitive networks and seizure networks are intertwined, as you can see. And what we often notice, or what comes to clinic, is when there are consequences of this. But I will say that we've seen several patients with epilepsy, with in fact medically refractory epilepsy recently, with off the charts high neuropsychological scores. And I'll talk a little bit at the end when I'm talking about future directions and possibilities about this kind of being an electrical surge throughout the brain. And at times you actually have extra electrical activity in some of these areas that can be harnessed. And so this is just an example of a digit span test, which is you're given a list of numbers to memorize, and you see how many you can memorize forwards, backwards, and in numerical order. The average is about 6. 7 is really good, and we've seen patients with double-digit scores who are getting epilepsy surgery recently. So I want to talk a little bit, well, maybe a lot now, about treatments and their effects on cognition, because this is a really important consideration. And again, what we'll talk about a lot, I think, is how these treatments can negatively affect cognition. I think lots of people are aware of, for example, with their medications, how it might make you groggy or tired or all these things. And so I want to caveat everything by saying that the biggest factor correlating with post-treatment neuropsychological test score improvement is seizure reduction. So getting your seizures down is the number one thing that improves cognition. And vice versa. We've also seen that with treatments that effectively reduce seizures, there's restoration of cognitive networks. So these things go hand in hand. And restoration of the cognitive networks, in fact, can predict the seizure freedom outcomes that you'll get. So starting with medications, and again, with that caveat of, if a medication effectively reduces seizures, there's going to be cognitive gain that comes from that. However, it itself also has often, with most medications, cognitive issues to balance with that seizure reduction effect. Our medications have gotten better with time, so our newer medications cause less of these issues. And the good side of some medications is the benefit on mood. As you know, many of these medications come with side effects even beyond cognition, though, to consider. But here's just an example of most of them having either negative or neutral cognitive effects. Oops. I think I just lost my screen. Let's see. Is that, can you guys see my presentation?
Yes.
Yeah.
Okay.
Yes.
So let's talk about surgery next. And with surgery, to kind of make it as simple as possible, there's really 3 strategies. Take out the part that's causing the seizure, and the part of the brain around it. Block the path, so make kind of highway cuts kind of things to stop the seizures from being able to spread through the brain, or modulate it, which can be electrical stimulation, which works in different ways. This can be pacing or halting the seizures. It can be kind of distracting the circuitry, but without actually removing any brain. And the cognitive effects that you get with any of these are variable depending on whether you're approaching the dominant hemisphere or the non-dominant hemisphere. And I put a question mark there because I think it's less different than has been thought. I think there are things that are easy to see right away when you impact them, like if you halt someone's speech or you affect someone's arm function. But the non-dominant hemisphere has these widespread networks of things that affect your ability to sense emotions, to make decisions, to kind of put these complex tasks together. And so while you may not see the effect of that, in the days after surgery or during a seizure, for instance, they can still have impacts on quality of life and how you interact with people and with the world, and your ability to pursue your goals. So while I think there are differences, they may not be as big as has been assumed. And so the things to consider in understanding the dominant and non-dominant hemispheres before you get to the diagnostic tests is the handedness of the person, as well as the handedness of that person's parents. And then the distribution of the brain gets complicated. So for instance, when it comes to language, it's more likely to be on the left, even regardless of handedness. Emotion, though, is something that's more likely to be contralateral. But as you can see from the figure here, there's a spectrum, regardless of your hand, of how your brain is laid out. We say in medicine that patients don't read the textbooks, you're individuals. And so that's why a lot of the tests that your epilepsy team will do are so essential for understanding what your brain looks like. So considerations for surgeries that are resection surgeries, there's different types, and what we've been doing through the years is really trying to restrict to a smaller and smaller region that's going to give us, get out all the culprit tissue, seizure generating tissue, or as much of it as possible, while sparing as much of the neuropsychological function as possible. And so we've come out for
when the seizure network is restricted enough, selective amygdalo-hippocampectomy being the best resection option for temporal epilepsies, for instance. And this has significantly less decline in verbal memory than the full temporal lobe resection, with comparable efficacy. And there's differences in efficacy based on where epilepsies are located, as you can see here. The other option is block the path surgeries. And let me see if this video will play here. So I wanted to talk a little bit about there's different ways we can separate the two lobes of the brain, or we can separate a particular part of the brain from the rest of the brain if we can find a focal epilepsy. And the most common way of doing that is laser interstitial thermal therapy, which I think the name is a bit misleading, but it's really introducing heat in a laser targeted way to a specific area, which is what you saw on this video. So there's better cognitive outcomes because it takes out less actual tissue. It doesn't take out tissue, but even what it burns basically is such a smaller specific area than would come out if you did an actual resection. There's questions of whether you're getting enough of the network then, and outcomes sometimes are not as good in terms of seizure outcomes as with a full resection. However, cognitive outcomes do tend to be better because you're taking out less, but again, not as good as the next option that we'll talk about. And this is a neurotherapy, so there's limited long-term outcomes data. And so neuromodulation, there's three major types of this: vagal nerve stimulation, deep brain stimulation, and responsive neurostimulation. So the vagal nerve affects lots of different things. And let's go to this slide here. It controls your digestion. It controls your cardiovascular system. It can affect speech through your nerves and muscles in the neck. So it has lots of effects. And then, it affects basically your parasympathetic nervous system and kind of the hormones and things and the state of mind associated with that. So sometimes people are actually, or the people behind it are starting to research it for being able to take advantage of some of these widespread effects of it. And it can have widespread effects, which can be beneficial in some patients, and it can be an issue in some patients. A really interesting case I've seen is, it can affect sleep apnea. And I actually saw someone who, when their battery was changed and increased, it actually increased their sleep apnea, which I think reduced their sleep and worsened their seizures. So the importance of thinking about a person as a whole person when you're treating a specific disease. Deep brain stimulation also it goes to the anterior nucleus of the thalamus, and the thalamus affects this circuit called the Papez circuit. That's a really part of the memory and cognitive circuit, but it's such a gate to other parts of the brain and can affect lots of things, which is advantageous for its seizure efficacy. That's one of the reasons why it's where we target, because it has this widespread reach and really good seizure outcomes because of that. In terms of cognitive side effects, we haven't seen so many that are described in epilepsy yet, but it's a newer therapy for epilepsy. And there is longstanding use of it for Parkinson's disease, which targets a different location. But with that, we do see cognitive issues. And so there's research now being done into, can we change the way that we stimulate, the type of frequencies and things that we use to still get the great effects from it, but to improve the cognitive outcomes as well. And so, once again, giving you the other side of the coin there, that there can be benefits in addition to these consequences. So mood is something that's actually known to improve at times as a result of non-dominant hemisphere lesions. And we see patients who will have resection or transection on that side and have mood improvement as a result of that. Stimulation also, I research it because of this potential. It can improve memory, consciousness, mood, appetite. And in fact, it's used for a lot of these indications. Here's a picture of the wide range of symptoms that deep brain stimulation in various locations with various stimulation parameters is used to help with. So there's a lot of possibility here as well. And I'm really happy that the community is starting to research ways that we can actually get more cognitive enhancement in patients with epilepsy. And so there's a review article that came out a couple of years ago that looked at medical, so different non-invasive therapies that can improve cognition in patients with epilepsy. And I've highlighted the ones that I think they showed were effective. So memantine is used commonly in Alzheimer's disease, but this was something, I like the study because it looked at effects on seizures as well. And it didn't increase seizures, but did significantly affect many mental status exam scores in a good way, with a pretty lasting effect over their treatment term. And then with methylphenidate, they had variable outcomes in 2 different trials that they looked at. So it's questionably as impactful on cognition or memory, but it did seem to be impactful on mood. And similarly, different ways of brain stimulation. So applying a magnet outside the brain to direct electrical currents, targeted directed electrical currents from outside the brain are the 2 non-invasive options that they looked at and had promising results in terms of improvement on neuropsychological tests with both of them without meaningful effects on increasing seizures after. So again, that's a good thing that says that these therapies could be promising for this purpose. So a little bit about how to consider electrical stimulation for cognitive enhancement. To very much oversimplify it, there's 2 big categories or 2 big flavors of electrical stimulation. High frequency, which can be in the range of 50 hertz, or low frequency that's in the range of 1 hertz. And the thought is that these are doing different things. So with high frequency stimulation, you're kind of trying to catch a seizure and stop it in its tracks. And with low frequency stimulation, it's like tapping your foot, providing a pace. And so you're not going to stop a seizure, but you'll eventually distract it and you'll prevent more seizures, is how it looks like these 2 are working. And so maybe expected from those effects of them, the theory is that high frequency stimulation is stopping neuronal communication, so sort of silencing the signal, and that low frequency stimulation is actually activating and enhancing, pacing the neuronal signal. A lot of studies have looked at, there's actually tons of companies coming out these days and efforts for cognitive enhancement in healthy patients. How can we make this commercially available? And there's a lot of research looking at this. And the research is variable. So what we find is there are effects, and there are effects with lots of different paradigms. And sometimes those effects are great, and sometimes those effects are actually detrimental. And it matters exactly where you stimulate and exactly where on the cycle of forming a memory, retrieving a memory, holding on to a memory you stimulate. And so it's something that needs to be done very carefully. And these are mostly with high frequency stimulation. The other things that have been looked at are low frequency stimulation And the study I've highlighted is the one that was actually tested in epilepsy patients. It's a paradigm that's based on one that I designed, so I'm very biased on this one. But this was looking at stimulation of the white matter tracts connecting the hippocampi in patients with epilepsy. And it actually improved memory, improved visuospatial recall, and decreased epilepsy bilaterally. So there's hope for this in epilepsy. And I'll talk a little bit at the end about why I think low frequency stimulation may be safer, and why I actually think there's there's more promise in being able to modulate memory in people with the extra electricity that epilepsy provides. And so this is what I was talking about with being very careful about it, that timing is everything. And this is basically looking at when you are stimulating. So if you stimulate while you're forming a memory or encoding, it improves your ability to recall that memory later. If you're in the states of good encoding anyway. So the brain just has these natural cycles within it. If you stimulate at the peak of that cycle, wow, you really improve the memory. But if you stimulate at the down part of that cycle, you can really enhance the down. And so timing is important. And this was seen also in a rat study, just not going through the details of it, but here where they looked at stimulation when the rat is learning something new, holding on to that information, or trying to act on getting a reward based on being able to show that they remember that information. If you stimulate during that third retrieval phase, you really decrease accuracy more so than if you stimulate during the other phases. So finally, what I also think is really cool, and maybe some of you have seen this, Mozart's sonata for two pianos in D major has been shown to decrease epileptiform discharges between seizures and decrease recurrence of clinical seizures. And people have actually looked at this compared to other pieces by Mozart and compared to pieces by Beethoven. And while I'm not here to say there's something miraculous about this particular one, I am here to say again that cognitive parts of the brain and your seizure network intertwine, right? They're inseparable. It's one brain. And music has independent components of melody, harmony, rhythm, meter, memory, imagination, emotional response. So it engages so much of your brain, and it involves these complex neuronal networks. So it's an important therapy. I think toddlers with musical exposure early on have been shown to have bulkier highways or fiber tracts. Oh, I see someone that said they've seen these studies. Yeah. And everything has a flip side. So I will say that if music can help epilepsy, that also means music can trigger epilepsy. And there is something called musicogenic epilepsies where people have these triggers. And so with everything, lights, music, stress, or strong emotional reactions, things that are triggers, I would say that what that tells you is that network, that trigger wakes up, probably talks to the network that your seizures travel through. And those things can go two ways. Often the things that are triggers can be used with the magic buttons in some ways to modulate the epilepsy. It is one network. And so this study that looked at EEG changes with that sonata saw that while listening to the music, the prominent frequency of the brain changed from 1 hertz to 10 hertz. This is what we call the alpha rhythm. So when your eyes are closed and you're at rest, it's your default mode network that's being activated, which pretty much means every other network that's involved in doing something specific is resting. And this is kind of your brain linking all of it together. This is when things like storing memories can occur. It's a rhythm that's really activated by meditation, and you actually see huge alpha rhythms in people who meditate a lot, and also associated with the flow state. So maybe that's something that this sonata is bringing out in particular. And along those notes, other treatments that have been researched by my former advisor and or both advisors in Cleveland Clinic include auditory tones, so at 1 hertz or at 40 hertz, and lights to stop seizures. And I've actually had patients reporting doing things like math problems and being able to stop seizures in their tracks. And then there's research on tones during sleep, enhancing memory. So with all of this, I think you can see that the map making is the essential part, understanding where things are in your brain and how they interact. And these are just some ancient maps from the various 1900s, and one that I thought was a really cool hat map of the brain that would be fun for us to make. So this is what those maps allude to, trying to block off sections of the brain and assign a function to them. And while the types of functions we've described have changed a bit since the 1900s, this mostly holds for the most part for the majority of the population. We can say this function is roughly here, but not really. So if you think of it as kind of a messy closet, the pieces are there, the idea is there, but actually no two brains are organized alike. And things move around, so we know that it's not just about blocks where functions go, but it's about these networks that assemble and reassemble. So when your language network is activated, you have this circuit that forms and things that actually spatially reassemble, and vice versa with kind of all of the functions. And your seizure network is doing the same thing. And so really it's more about thinking about things like this, like a messy closet, and understanding how that seizure network is intertwined with other networks, which is hard because these things change in space, they change in time, and they're personalized. So I don't know if you guys know the story of the elephant and the blind man, but it's these 6 blind men are feeling this elephant, and depending on what part they grab, they describe it very differently. And so one thinks it's a rope, one thinks it's a fan, one thinks it's a brick wall, one thinks that it's tree trunks. And if you read neuroscience research, you see the same thing going on. We look at genetics and say this, and we look at molecules and say this, we look at electrical activity and say this, and we do brain imaging and say this other thing. And so I think that when it comes to applying all of this clinically, more is better. And this is why we ask you to get so many tests to try to be able to make this picture of the elephant on the bottom left. That's, okay, how can we put these pieces together that we're learning? And some of the things we're looking for is, that category, that typical picture of the brain that you saw that says where things are kind of next to each other, so in space. But then also what talks to what. So, sort of the domino effect of the signal traveling through the brain. And that's that temporal layout as opposed to the spatial layout. And then for, anyone who may live in a small town and you want to get to the neighboring town that's right next to it, but there isn't a road that goes directly there, and you have to get on the highway and go around and go through traffic. That's sort of your topological layout, where the roads are. So things may be next to each other, but still hard to get to. Even if there's no traffic and there's a fast connection, it's still a long connection. So we have to look at the brain all these different ways. And what we're doing is making these 2 maps, a seizure map and a cognitive map, and figuring out how they fit together. And that's really what you want to advocate for to get the best seizure and cognitive outcomes. And so the seizure map is kind of like a Where's Waldo game, if you guys remember that. It's these things that look alike. If you've seen an EEG, it's a lot of squiggles, and you can look at this MRI as much as you can see behind the Waldos, and see that it can be tough to see things. And so it really is a game of finding this thing that kind of looks like the things in the background, and there's other things that kind of look like it, and figuring out which one is the real Waldo, or are there more than one. And often these lines are not well, you get multiple Waldo-like things. So there can be a place where there's a structural lesion on your MRI, and a slightly different place where the EEG says is the most active place, and a bigger place that may or may not include both of those, that the EEG says are all the places that the seizure travels through. And you may have seizures that are sometimes small and sometimes big, and so those can be having different borders as well. So the better we can map this out, the better we know what the maximum area that needs to be treated is, and the minimal area that would give good outcomes. And then the other thing is building that cognitive map. And so for me, this is done very much with the help of so we do this largely for research purposes as well as clinical purposes. This is done to some extent for clinical purposes, but usually more so if there's a high risk. So if the doctor thinks there's a reason to do a lot of extra looking for things. And so this is a picture of my team, Rochelle, who is an amazing junior specialist in the lab, and Alyssa Weekly, who's the neuropsychologist that we're so lucky to work with to help us understand the brain layout, and understand the right tests to do to learn things about where things are in the patient. And this is just an example of, so what we're doing is mapping out, having patients do different tests and saying, okay, I got it. Language is here. Arm movement is here. And it's sort of like that mind game where sometimes we'll do things and we get these discharges. We find seizure activation. And so we're seeing where those things come together, and which one of those is the Waldo, is the seizure focus, if that's clear, which it isn't always. With this, what we do is make a personal brain map. So like I said, there's an expectation of where things would be. And this is an example of a layout across the cortex of where motor and sensory parts are. So this part of the brain is expected to control your tongue, your lips, your eyes, your hand, etc. But with testing out those functions, we can see where things actually are in a person's brain, and it may be different. And so this slide is meant to go through, I think the most common thing that my patients say, or one of them is like, another MRI, or I just got a picture of my brain. Do I really need another one? And here's an explanation of kind of what we're doing when we get these tests. So again, the bottom line is seizure map, cognitive map. How do we put those things together? And different tests are helping address different categories of this. So starting with the seizure map, and I'll start with the imaging study that's outside of the chart, the CAT scan. The CAT scan is something that you get if there's a sudden worsening, a sudden change, and you go to the hospital. It's this blurry image that's looking for big pathologies. So if there's blood in the brain, if there's an infection in the brain, if there's a tumor, if there's something obvious, it just says, yes, there's that. For the details of your seizure map, your cognitive map, anything about your actual brain anatomy, that is not a sufficient image. So that's outside of what if you had that, still need an MRI. And that's the next place to start, is your basic MRI. And so this is used mostly for understanding where seizures may start from, by looking for any abnormalities in the brain structures. But of course, depending on how abnormal they are and where they are, it might also give you clues to cognitive changes that are happening. So that's why it's in the middle. It sort of addresses both, but mostly the seizure map. The next is the EEGs, and there's sort of 3 tiers of this. So there's an outpatient EEG. If that doesn't answer the question, there's a hospitalization with an extended EEG. And if that doesn't answer the question, and medications aren't working, then there's going to be electrodes that are implanted in the brain for an intracranial EEG. And there's actually one more tier. If that doesn't answer the question, then we do something called source localization, which is now can be over 200 electrodes to be able to get a sense of if we can find a place maybe deep in the brain where all of this projects to. It's not perfect on its own, but when we put all this data together, we do a little better at building the elephant. So that's kind of the electrical part, the dynamic part of where things come from, and then the static part. Do we see a lesion? Sometimes there's no lesion, that MRI is normal. And so then we do functional imaging. And one is to look for brain metabolism. So if you have a part of the brain that's always taking more energy, then you'll see it light up on the PET image. And that can happen even if the MRI was normal. But sometimes, seizures come and go. So sometimes your PET can be normal because that place that's taking up more or less energy is only doing it sometimes. So the ictal SPECT is something where you do a PET at a non-seizure time, do a PET at a seizure time, and subtract out the difference. So you're really trying to find a spot that you can pinpoint the seizure focus to. And then finally, what we look at is the connections. So if seizures are, what's connected to what? How are my seizures spreading? How is my cognitive network connected? And so this is your diffusion tensor imaging. And I think this helps with both questions, your cognitive map and your seizure map. Finally, something that we do is when I'm calling boring or low frequency stimulation, there's 2 types of electrical stimulation for diagnostics that I'll talk to for building these maps. And during this stimulation, patients are able to fall asleep. They're not really engaged, but we really look at the responses of one part of the brain to another, what's talking to what. So now the cognitive map. We do all of that to try to figure out where the seizure circuit is. For the cognitive map, the most important part is the neuropsychological assessment. And this is working with a neuropsychologist and doing hours of different tests to understand where there are issues that are irreversible, where there are issues that would be reversible with better treatment. And also the layout is your emotional layout on landscape on your left or right side of the brain, where exactly. If that's, if that gives us information of that things that are important are far away from things where seizures are coming from, great. We have all the information we need. But if they seem close by, then we want more detailed information. So the functional MRI is one way of, while you're getting an MRI, doing language testing, doing motor testing, doing memory testing, and seeing what part of the brain lights up when that's activated. The kind of opposite way of asking a similar question is the WADA, which is injecting anesthetic into either hemisphere. So it's seeing if that part of the brain were to be disconnected or taken out, what would actually be compromised? What does it look like when that side of the brain is anesthetized? And so this really helps us predict surgical outcomes to language, to memory, to visuospatial function. And then what we do is another type of stimulation, which is high frequency in terms of parameters, and this is active. So this is stimulation with a whole bunch of tests, and I'm going to talk about both of these right here. So starting with the low frequency stimulation, as I described a little bit before, this pattern of current delivery is thought to activate networks and connect networks that can be connected. So it's sort of injecting, sort of putting water through a pipe and letting it flow where it can flow, where those pipes are. and it shows us what's connected to what. And so the way that this is done is, in patients who have 100 electrodes or so, you stimulate one pair and you record the response in every other one, and are able to see which one had a really big response versus really little, and figure out what's close to what electrically as a result of that. And so with this, we build your personal kind of highway map. So the stuff on the left is the information we collect. And a lot of this is looked at by a grad student in my lab, Ariana. And so, you can see you stimulate and you collect these evoked responses in all these contexts. And then what you do is you build this highway map as a result of that. And it's really figuring out, okay, here's where the important landmarks were, and here's where the roads are that take me from one to another. Really looking at what talks to what. So what are the things that fire together? What are the things that fire next when those things are firing? And it helps you get a lay of the land of both of these types of networks. And so with this, with the high frequency stimulation, the way that this works is it disconnects. So think of it as a zap. And while it's happening, that highway is blocked off. The signal isn't going through. So we ask people to speak or read or sing or look at and remember objects, and we deliver this zap while we're doing that. And if they had an interruption in that function, then we know that that function is located there. So it builds a really precise cognitive map, and especially if that's a part of the brain that we're thinking about taking out, helps predict exactly what would be a possible response of that. Some things to consider are brain remodeling. So a change that you see or a change that you have right after surgery may get better. And understanding people's brain plasticity, or how we talked about seizures being more severe and cognitive symptoms being more severe when they've gone on longer. But those brains are often also more remodeled and actually may have more backup. So with all things, it's complicated, but there is a lot to consider. So with all of that, so all these tests are helping us build this map. Here's a kind of overlay of where each of these tests might say things in your seizure network are. We build that seizure map. We say, I think Waldo is here. We overlay it with the cognitive map. And then based on that and your outcome goals in terms of both of these things, come up with ideas for whether taking it out, cutting the pathway, or pacing it might be the best solution. And so I want to talk about how to get the best goals. So how to think about and really define what your goals are and how to communicate that with your team. And this is motivated by something I often see, which is understandably the primary goal is, oh my gosh, I want seizure freedom and I want to drive whatever it takes. And when we're saying that, we're imagining what life looks like afterwards, and that whatever it takes may not be true for you. So I think thinking through that, like, no, go through ideas of exactly how to do that. This is a card that I got from my mom for Halloween that I thought was really cute. But just to say, like, yes, my heart bone is connected to my head bone, and knowing how you're connected is important too. So paint a picture, have your vision board, know exactly what life looks like for you with the treatment that you're researching in vivid detail. So how do your symptoms have to change for whatever treatment you're considering to be worth it? Are you looking for fewer seizures, no seizures, some reduction in seizures, enough to let you do what? Is it predictability what matters? Is this worry about they can happen anytime, or in particular, they can happen when I'm doing this thing, the issue? Is it the symptoms that happen between seizures that are the biggest issue? So less brain fog, less medications, the ability to capitalize on my time between when seizures are occurring. How do medications and doctor's visits have to change for a treatment to be worth it? Are you looking for fewer side effects from medications or fewer dose administrations? Is it, less cost? Let me move. Oops. And then what are you hoping to be able to do that you can't? So for instance, I want to be seizure free so I can drive is so common. And considering that seizure freedom, if that's, depending on if that means resection, if that means more aggressive resection, is this affecting your vision? Is this affecting your coordination? Is it um, also going to impair your ability to drive? So think about what goals are really important. Is it concentration and excelling at school and work? Being able to participate in social activities that you might avoid? And to help with this, describe yourself. What are you doing? Are you the comedian, the singer, the poet? What makes you you? What is it that needs to be preserved or enhanced? Most importantly, and I think try on different shades of how this looks, because there's probably not going to be something black and white that can be prescribed. It's options. With this, here's the range of cognitive concerns I can predict. Here's the possible cognitive enhancement or benefit that could actually come out of that, and understanding what your personal plan may look like. So if, for example, your goal is no more seizures, why? Is it so that you can write books without brain fog days? What would make that worth it? And what would not make that worth it? So yes, resection for the most efficacy possible is worth it if I can become a writer, if I can meet those goals. But it's not worth it if my skills are going to drop as a result of that. And then similarly, understanding how to think about the side effects. So for some people, a naming issue or a slight language issue is no big deal if they can still communicate, hang out with friends, do well at work. But for some people, I met someone whose family is multilingual, and she really prides herself on talking to the right person in the right language. And so that being affected would have been a huge issue, even though it wouldn't have affected sort of day-to-day life with people who speak the language that she usually speaks. And an example of this is a voice catch. A little catch in sound production is not a big deal for a lot of people. But if someone's a professional singer from a family of musicians, this might affect a core part of the identity. But maybe if a little bit, if it happening here and there meant more being able to go on stage confidently, more driving, getting off of medications, maybe that trade-off is worth it. But maybe if it means a decrease in seizures, so if we present a plan that's really going to preserve that, but we're predicting seizures go maybe from 10 to 1 a month, maybe that makes it not worth it. So really, I think detailing what's worth it and what's not, maybe making these charts for you would be helpful. And then for loved ones of patients, sharing with your doctor what they should know about that patient's ability to navigate the decision. Like we saw, seizures affect networks that affect mood, that affect decision making, and all of these things. And so, if the person that you love with epilepsy has trouble making decisions, that could be part of their disease. It could be part of having a long-term disease, but that's something important for their care team to know and consider with your input. If that person's mood is impacting their outlook and goals, that's also important to consider. And then can affect executive function is often the ability to forecast, to visualize, to think about the future. So again, helping everyone understand that and being able to advocate for the person with epilepsy, sharing what makes that person uniquely them, what they enjoy. Are they the trivia queen? Are they the person that has awesome fast reaction times at video games? And what they're really longing for, is it scuba diving? Is it independence to not have to be driven anymore? Is it to be able to perform better and share whatever their talent might be? And then finally, there's an idea that ignorance is bliss. And Einstein actually has a quote that the mind that opens to a new idea never returns to its original size. And I say this because I've seen people who, when their seizures are really bad, and we do these neuropsychological tests and they get low scores, but they're content. And as things improve, actually, their scores get way higher, and their circuits are working better. So they're now more aware of the mistakes they're making. And these are the people who are actually more likely to even stop the test halfway, because they're so distressed by the mistakes they're making, even though things have improved. So being able to share that, I think always ask for more, ask for an advocate for what you want, but actually share any changes that you're seeing and try to step back and see what changes may be there, even if they're not what you want. Knowing how the initial treatment impacted things helps make a better next treatment. And, I think the fear can be, if things are better, but they're not as good as they should be, and I don't want to stop here. I absolutely agree with that. Don't stop there. It's get a good life, whatever it takes to get the best life possible. And then, finally, because we talked about these cognitive and seizure circuits being so intertwined, the symptoms that you have in between seizures can be clues about where your seizure circuits are. So describe these. What symptoms do you have between seizures? Do they fluctuate? How much do they fluctuate? This gives a sense of whether that pathway is maybe irreversibly impacted, or actually has a lot of potential to improve with seizure treatment. How do those symptoms relate to seizures? Do you have them anytime right before seizure clusters, or only with seizures? How do they relate to medications and to lifestyle? Are there things that you can do to make it better or worse? Those examples of music or math. I had a person, when they're organizing pictures, it can ward off seizures or cause seizures. Same trigger and same relieving factor. But again, those things are clues towards these circuits and how they're interacting. So I have lots of hope, and just a little bit of teaser towards directions of my research. We already looked at this picture of how things intertwine, and now looking at it as pipes. And the reason that I say that, I actually think there's a lot of potential in people with this extra electricity. If you think of it as water going through the pipes, and the propensity for seizures can be thought of as actually surges of water going through the pipes. And so here's an example of channeling the flood to irrigate crops. So when there's more, you actually have opportunity to divert it into directions that you want. And this is a big part of what we're trying to do. And so my main research goals, and here's my research team who do so much. I want to describe the first picture, which is my student testing out our electrical stimulator before trying it on patients. And I think some of our techs who are signed up, thank you for coming. And it was our head tech's idea to have her test the electrical current on herself and be her own voltmeter, which she did. And then more of my team, including at our epilepsy family camp, which we had so much fun attending. But the goals that we're trying to do, so right now we're working on extracting key features of seizure state transitions and establishing a correlation between cognitive and seizure states. Like I said, both of these things fluctuate. They fluctuate in space, they fluctuate in time, and trying to really pinpoint concretely how and when those interact. And it really is like chasing two moving targets. We're next looking at the correlation between the dynamic and cognitive and seizure states, and extracting features that give us high predictive value of transitioning to a desired or not desired cognitive as well as seizure state. And the reason for all of this is to develop neuromodulation that can affect where these things intersect to be able to help with both of them together. So diverting the flood in a way that affects the seizures in the direction that we want and affects the involved cognitive circuit in the way that we want. So it's really learning about the system that's there in order to draw out its unique power in the best way possible. And the future is now. I think with research, things are generally believed when they go into textbooks from research papers. And we've written a chapter recently on the importance of both cognitive and seizure effects of treatment. So thank you for your interest. I'll leave you with one last example of seizures and cognitive circuits interacting, which is Van Gogh. Epilepsy then, or seizures then, were called epileptic fits, and the razor to the part of the ear actually occurred during an epileptic fit. For those of you who may not have known that he had epilepsy. And then finally, digitalis is a drug that affects potassium currents. It is not a drug for epilepsy today, but it was then. And a side effect of it is seeing yellow halos. And so it's thought that starry night may actually be a result of cognitive circuits impacted by epilepsy treatments. Talk to me. Time for you to talk.
Thank you so much, Dr. Toprani. This was a wonderful presentation. And thank you so much to your team as well and all the research that you guys are doing.
I'll thank them too, and everyone here for everything that you do.
Does anybody have any questions for Dr. Toprani? If you are comfortable, you can unmute yourself and ask the question. And if you prefer, you can put it in the chat as well.
I made a mistake. I have a few questions.
What is it?
Okay, first I remember, well, the left temporal lobe has to do with language, speech, mathematics, and I forgot the other thing. Wait, language, speech, mathematics, memory is supposed to be on that side, and certain cognitive abilities. So if my seizures come from the left side, but my memory when I was diagnosed transferred to the right side, does it still get affected? Like the seizures come from the left temporal lobe, but my memory is on the right. So does my memory still get affected?
There isn't an overall answer to it, right? And that's why all these tests are there to figure out your unique circuit. It's possible, and it depends on your unique circuit. It sounds like maybe based on your handedness, memory would have been expected to be on the left. Maybe if you had seizures early in your life, it actually compensated and found safe harbor on the right side of your brain. The
Yeah,
left
that was covered when I was diagnosed. The date I was diagnosed, the memory was on the right side of the brain for some reason.
and the left and right temporal lobes actually have this wire that directly connects them. Because important stuff like language and memory, like in your case, can be on other opposite sides of the brain. And those are things where it's important for them to talk to each other fast in a healthy brain. And so the flip side of that is that seizures can spread fast. So your memory on the right side of your brain, if seizures are on your left side of the brain, can still be affected because those seizures probably quickly communicate to the other side of your brain, at least at times. I bet your brain did cool things to compensate for seizures if your memory moved. So I don't know what the layout of it is, and
That's okay.
anything is possible.
No, you did well. And can I ask you another question?
Of course.
I was told by Carlos I'm the one that has the most questions. You have to excuse me on that balcony. You said that the mood goes down on phenobarbital, and what was the other thing?
But
Mood. You said two other things.
with what?
Oh, you said phenobarbital on the medication thing. Mood, memory, and something else goes down with phenobarbital. The arrows went down.
Yeah, most aspects of cognition. It's a big one. Mood is variable, and again, all of these things.
Good.
Phenobarbital is effective, and so by reducing seizures, it improves a lot of these things. But over time, the cumulative effect of the drug itself, besides its seizure reducing effects, are to significantly affect cognition.
So permanently? Because I'm on it for 29 years.
So it's varying amounts in various people. I've seen patients who are on it for 70 plus years who actually have structural changes in the brain as a result of it. But nonetheless, as we weaned it, cognition improved and other side effects, things like drowsiness, improved. So that's the thing with the brain. It really adjusts to things and rewires and reshapes, so it's really a matter of what your personal brain will do. We can say what the averages are, but that doesn't mean that holds for you.
Because weirdly speaking, my memory increased somehow on my last neuropsych test after I was lowered on my lamictal.
Yeah. And again,
And
this is, for the drugs that do have effects of impacting memory and things. Again, the biggest impact is reducing seizures. And if you reduce seizures, the seizures are occupying your cognitive circuits. So once you free up the cognitive circuits to do what they're supposed to do, that often outweighs the effects of the medications themselves.
so if it's under control from 3 to 6 months, like usually I stay under control every 3 months, 3 to 6 months. So less, I guess, damage is happening.
I'm going to try to refrain from giving personal advice about your situation since I don't know the details of your situation.
I took advice from Duke University at a lecture they had.
Yes. So take this advice as
just
general.
No problem, doctor. I didn't mean anything. I just got curious. I ended up I got on I did this to Duke University, and I can be quiet.
And curiosity is important, and I welcome general questions. I'm going to be wary about answering questions about what's happening in particular.
No matter what, you did a great job.
Thank you.
So we do have another question on the chat here, and it says, can you address research into tonic-clonic postictal cognitive effects, both in the immediate 24-48 hours and a full month postictal, and if there's any treatment being used or research for post-seizure recovery?
Yes. So the post-ictal state, like all the seizure states, I think is very interesting. What we see on EEG is this suppression. We've looked at actually the different frequency bands, so ones that encode learning and one that encode this alpha, this sort of meditation rest network, and they do different things during that state. Like you're alluding to, some people have no postictal state, so seizure back to what they were doing before. It can be minutes, it can be hours, it can be days, especially in patients who have other things that have affected their brain tissue and brain circuits. In terms of your question of what might affect the duration, and then, this isn't something you asked, but the symptoms during it can vary too, right? Like most commonly, it's being quiet, being really fatigued, sleepy. But for some people, especially with temporal lobe epilepsy, after their seizure, it's being really agitated, kind of superhuman strength can come down. I know our clinical team is very aware of being able to keep patients safe during this. And so, we've looked at, are there factors that affect what your symptoms will look like? So looking at things like gender, like age, like type of epilepsy, if it was generalized or not. And interestingly, there wasn't really something that came out. The biggest factor was how long someone has had epilepsy, and whether it has generalized. So essentially, the severity of it is what plays the biggest role into predicting whether there will be a postictal state. And we know the opposite, that if there is a long postictal state, that can be a really concerning state. So the risk of SUDEP can be high if you have more of those types of suppressed states. And that's thought to be because, for instance, if you're not able to move during that state and you have more periods where you're not able to move, that's more dangerous. In terms of how it's expressed, we found that male gender is more common when there's this really agitated postictal state. And then in terms of whether it can have effects months later, I'm not aware of research that looks at whether the postictal state has effects months later, but having more and more seizures certainly has cumulative long-term effects. And in fact, one theory is that the postictal state happens in brains as this natural break. So it's actually stopping the brain from accumulating the damage of ongoing seizures. And the worse the seizures, the more important a really strong break is. There's a lot to learn, but that's kind of what we know so far.
Thank you so much. And then another question was, are you able to address PTSD specifically caused by seizure damage?
In what way?
Would the individual be able to share a little bit more about their question that they wrote in chat, if they're able to?
Hi, yeah, that was me. Can you hear me?
Yes.
I find that after my tonic-clonic seizures, my sort of classic PTSD symptoms, I don't have a diagnosis, are very profound. And the older I get, the worse it is. And I've been assessed, and I don't fill the PTSD diagnosis. But those specific seem to be directly, and then they last only about a month, and then it seems to go away. And I did see some research from France that discussed this, that some damage, especially in the postictal period, was specific, but it didn't describe the actual damage that was happening.
So again, I fear it's going to be the answer for a lot of things. Different brains do different things, and it really depends on what your brain is doing. It is possible that seizures accumulating are causing damage. That's more often experienced as a loss of symptoms than an increase of symptoms. So if what you're experiencing is more PTSD symptoms after seizures, if I'm understanding correctly, that's possibly more an effect of the electricity going through and kind of waking up that circuit. And I don't know if you have temporal lobe seizures, but PTSD, no. A lot of seizures go through the areas of the brain that are involved in PTSD. So it's possible that it's waking up those areas and kind of reminding your brain of those symptoms, and so they get expressed and calm down if they're kind of happening after seizures for a while and then calming down.
Thank
Yeah,
you,
if I
Dr.
could ask two quick questions. I do appreciate the presentation and the distribution of the video, the presentation. I really do appreciate that. You talked a lot about the correlation between the impact of the seizures on the cognitive abilities. Two variables that you didn't talk too much about were seizure frequency, and there's such a broad spectrum of seizure frequency. You know, some patients can have 1 to 2 a day, other patients have 1 to 2 a year, and there's everything in between. And so are there any studies showing the impact of cognitive abilities with the factor of seizure frequency figured in? That's I guess my first question. And the second one is the same question on seizure type. Talked a lot about the effect on cognitive abilities, but what about comparing those, again, using the old names of, tonic-clonics versus complex partials versus simple partials? How does that map out? Or is it the same across all of those groups? So two different questions, timing and seizure type.
So with the first one, seizure burden tends to predict more cognitive effects, and seizure frequency is a big part of what factors into seizure burden. So it's how often they're happening, how long they last, how widespread they are, which is kind of getting at your question of whether it's using the old terminology, if that's what you're familiar with, which I don't even remember quite what it was, but is it simple partial or tonic? Tonic-clonic is reasonable even with new terminology, but how much of the brain is impacted? All of those things predict long-term outcomes.
Yeah.
As we learn more, it's getting more complicated, right? And so those were the slides showing that, there are people who have, like you were saying, seizures twice a year, and in between that, you wouldn't even know they have epilepsy if you got an EEG. And there's other patients with seizures twice a year, but every EEG you see lots of spikes. And we're seeing that cognitive symptoms can occur with those spikes. So another case of not every brain is the same, and it really depends on the fingerprint of your epilepsy, and on whether it's activating circuits in it can be in somewhat helpful ways in rare cases. And I think those cases are probably less well known because no one's complaining about the abilities, right? Those are things that you kind of find incidentally, but the trade-off is never worth it of having more seizures. And then in many cases, having it go through that circuit over and over and over eventually burns out that circuit. And so that's a risk even with the interictal spikes. In short, the more epilepsy there is, the more that you want to change, divert, get rid of it.
Agreed. Thank you.
Thank you so much, Dr. Toprani. It's about 8:15. I want to make sure I honor everybody's time. And I know I said 8 o'clock with that the presentation would end. So I just want to end with one more question. I know there were a few we weren't able to address, but the last one I want to be able to mention is there's someone that's currently in pre-surgical evaluation for TLE, and really appreciate the presentation, and it was super useful. The question is there some way that the individual can participate or help with these studies, or others also that are interested?
Absolutely. Anyone at UC Davis who's undergoing this process would be invited to be involved in research, and any center that does this research probably has, that does these surgeries probably has research, because when you're putting electrodes in, I think it's really important to learn what you can to improve what happens next year as a result of it, especially when people are excited to be part of that change. So wherever you're getting care, ask about it if someone hasn't already asked you about it.
Okay, wonderful. Thank you so much. Amanda said, how do we participate in the research if you are at UC Davis?
Ask your doctors. Ask any of your epilepsy doctors, and they'll point you to me probably, or just reach out to me.
Okay, wonderful. Thank you so much. Really appreciate it. That was an amazing presentation. And I know that there were a few questions we couldn't get to. I apologize about that, but I did put my email for those that would like to contact and reach out further. And if you have any other questions, please reach out to me and I can try to help in any way we can. Otherwise, I just want to thank each and every one of you for being able to come this evening and be part of our educational webinar that was presented by Dr. Toprani with UC Davis. So thank you again to each of you being able to be here. And again, Dr. Toprani.
Thank you. Thank you for your curiosity.
Thank you, everybody.
Thank you so
you.
much. I hope
Thank
everyone has a great
you.
evening.